morning to you if you are on the West Coast. My name is Dr. Jose Leon, Chief Medical Officer for the National Center for Health and Public Housing, and welcome to our Diversifying Revenue Streams webinar. It is a pleasure for us here at the National Center for Health and Public Housing to host this webinar. The National Center for Health and Public Housing is supported under a grant by the Health Resources and Services Administration, HRSA, and the mission of the National Center for Health and Public Housing is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and a range of technical assistance. The purpose of this webinar is to offer some ideas on how to strengthen existing revenue cycle management and suggestions for diversifying funding streams, implementing coding and reviewing performance measure reports. Our today's panelist is Ms. Zara Marsalian. Before I introduce Zara, I would like to go over some of the needs assessment results that we have conducted for the last couple of years. And one of the issues that we have found is that some health centers have not been using the appropriate ICD-9 codes, even though about 70% said in our last needs assessment that they have used the appropriate ICD-9 codes. Around 20 or more than 20% have said that they are not sure, and around 2 or 3% said that they haven't. Now, one of in regards to EHR implementation, one of the abilities to, once you have implemented EHR, is to reduce cost. However, the 2015 needs assessment shows that only or less than 10% of the interview PHPCs have been able to reduce cost. And for all PHPCs, around 60% of the payment form is through Medicaid. Around less than 30% of the revenues come from out-of-pocket, and some PHPC patients, maybe 2 or 3%, comes from private insurance. Based on that, I would like to introduce our speaker, Zara Marsalian. Zara is the CEO and co-founder of La Maestra Community Health Centers, and Sarah is a native San Diegan, and she founded La Maestra to provide healthcare and social services to help the underserved immigrant and refugee residents in the inner city San Diego community of City Heights to become healthy and self-sufficient. Since 1990, La Maestra has grown into a nationally recognized organization with 400 staff members serving over 45,000 patients annually, with locations in City Heights, El Cajon, National City, and Lemon Grove, and services across San Diego County. Zara holds a master's degree in organizational management and has been actively involved in community organizations and other nonprofits for over 25 years. Sarah is a fellow of the American College of Healthcare Executives, graduate of the National Association of Community Health Centers Excel Leadership Program and the Fieldstone Foundation Executive Learning Program, a dedicated member of several boards of directors and former president of the Council of Community Clinics. Without overdue, I'm turning this over to Zara Marsalian.
Well, thank you, Jose. Thank you very much. It's an honor to be part of this. Let's see, I'm just trying to get this slide here ready to go. Kind of jumped on me. I really am happy to be on this webinar and hopefully be able to offer some pieces of wisdom, lessons learned that we've been through, different kinds of suggestions that will be applicable to the participants. I know that many of these maybe some of the things we're talking about are going to vary between the states, but overall, I think we're all, as FQHCs around the nation, facing some interesting, challenging times with the, payment methodology being changed and different initiatives implemented that we all have to be, like very knowledgeable about and effective at demonstrating the outcome measures, which I'm referring to HEDIS and so forth, that's going to then affect all of our payment systems, whether it's managed care, through capitation, or whatever the contracts are that we have, and also the reimbursement from the state based moving from volume to value. So we're going to be covering some of the I guess the realizations that we've come to, and what we could have implemented before if we would have known, or somebody would have told us, hey, 3 years from now, you guys are going to have to be facing these challenges, so you better shore up on, hiring scribes and coders and so forth, or you're going to be stuck not being able to close your charts, do the initial assessments, and therefore you're not going to be able to collect what the plans owe you, or Medicaid. So, and I do also know that some of the states have not implemented managed care yet. So, I'd be happy to talk with anybody or via email or phone after this, or we can set up a time to just cover some of the basic setting up of contracts with managed care, negotiating different incentives and how to set that up in the contract so that later the state doesn't count it as revenue and then take it off of the cost report. All of those things have happened to us, so we'll be very happy to give that knowledge to, or heads up to, whoever needs to get involved with managed care at this point. So let's go ahead and start. I just wanted to give you a brief overview of La Maestra so you can see the volume, you can see the different kinds of programs that we have, how we started. We're very grassroots. We started with nothing, basically, in a converted residential house, and it was, built in 1920s, and we started the clinic in 1990. You can see the picture on the left side. That was an old house, and first what was there was a nonprofit educational program. We had 12,000 students that took English as a second language, vocational training classes to be able to prepare to qualify for the amnesty, phase 1 and 2. That was in, started in 1986. Well, from there we developed a preschool, family literacy programs, more economic development like job training, job placement for what Medicaid said was the hardest to place populations. And those 12,000 students said, what we need is health care here in our area, and we need a culturally competent providers and staff that are familiar with our traditions and want to work with our populations. So we thought, well, that can't be too hard, and so we brought on first it was 4 hours, Tuesdays and Thursdays. It was a pediatrician, and it just grew from there. Right now we are so the clinic's been here for 25 years. We have 5 medical, 9 dental sites, 4 school-based clinics, 1 homeless clinic called the Hope Clinic, and then we have a mobile that is dental, medical, mental health, behavioral, and we have telemedicine services also, and the digital imaging, MAMO, which is the big it's the big RV there that you see on the screen, and it is wonderful. It's got the tomosynthesis. It's got, so it's very, very clear, being able to see the breast tissue. the state-of-the-art mammography software. And it's the first in San Diego, and this sophisticated equipment is one of 3 that exist in the nation. So it's really fantastic. And if you have a chance to visit our website, you can see the video of what this looks like inside and the description by the radiologists about the equipment and why it makes such a difference. These are the numbers of patients and visits that we see per year. Patients, we're about right now about 42,000 unduplicated patients, and about 220,000 visits. We have an extremely culturally diverse community, even though we are in the border zone. San Diego borders Mexico, and we are within the 50-mile radius from the border. But we have a lot of different refugees that have been settled in our areas since, before 1975. And we never know which new population is going to arrive, but we do our best to incorporate them in our workforce. Our workforce is almost 500 now employees. So we have 30 languages now every day spoken throughout our clinics. And we, from the beginnings, had developed a program called Medically Trained Cultural Liaisons so that we could learn a lot about the cultures and the populations we're serving and incorporate them in the workforce here at our clinic. You'll see soon the screen that shows a beautiful flower, and it's called La Maestra Circle of Care, and it's all of the programs that we've developed over these 30 years and why these programs are there and how they integrate with each other. And this has a lot to do with the diversification of our funding as well, because we have expanded a lot on not only the comprehensive services for the medical clinic, but for the services we offer, programs, social determinants of health, enabling services, transportation, translation, and all of those things can be negotiated with the managed care plans so that we can hopefully recoup a little bit more on the contract side, revenue side, to support those services that we cannot bill for, but we know need to exist in order to be able to effectively manage the patients, serve the patients and clients, and then be able to record and prove that we did offer these services to meet our HEDIS measures. So this gives you an idea of our circle of care. The red are all medical, dental, mental health services. We have pharmacy, telemedicine, imaging that we talked about. And all of the other services have to do with wellness. It's helping achieve wellness, but they are not necessarily reimbursable, and they're not they are not direct medical services. But for our patients, our populations, this is what works, and this is what helps us meet our HEDIS measures, is addressing the social determinants of health. And hopefully soon we will be able to find more revenue to support these programs. We've gone out to different foundations and private individuals for support, and they see how much sense it makes, and they're willing to support some of the startup costs for these programs, and that's how we've been able to, throughout the years, keep them sustainable and moving along, and complementary now with all of the medical services. So one of the things that, our team got together, and I wanted to introduce, we have Alejandrina Arreizaga with us. She is our Vice President of Fund Development. And say hello, Ale.
Good morning, everybody. Welcome to La Maestra.
Yes. And Tom Vu, he's with us here too, and he's a Risk Management Director and actually an expert on many things, quality and so forth.
Good morning.
So, you know, we've been going through for years. How long have we had managed care here in San Diego, Ale?
Since 2002.
Yeah, since 2002. And since then, we've seen, you know, many other managed care plans coming in competing. Some close down, some sell out. Then you have new ones coming in. So it's a constant competition between them. And then you know, that in and of itself has been a big challenge for us and other FQHCs in San Diego County, because, you know, not just because we're managing the patient care and we get everything set up, referrals, all the paperwork down, the process, and then all of a sudden we find out, the patient's been defaulted, moved, somehow shifted over to another plan, and now we get to start the process all over again. So that, of course, is, you can see, costs us a lot of time, energy, money. There's been some standardization between the managed care plans here in San Diego, where instead of each one coming in doing their own audits, they now basically have grouped together on those specific functions. So that's been a huge relief. That doesn't mean that each one of these managed care plans do not have their own process or procedure for determining how they're going to count how much, you know, the wellness of their members has improved. You know, chronic disease patients, you know, how well have we done, for example, in meeting certain criteria for, you know, helping people's health improve. Each one kind of has their own formula for determining that, and it depends on what software they have, how many staff they have that are going through their reports. And then it's when we found a lot of discrepancies between the information that we record through our electronic health record. We have NextGen, and the software that then we've incorporated to deal with the chronic disease patients, and like I2I, and then the POP IQ, which is like the network version. So a group, you know, a group of clinics, let's say, in San Diego can see what the overall, the more global picture is on the I2I for the different chronic diseases, and measuring how well we're doing with improving our patients' well-being. So, you know, that all is very complicated in terms of making sure that that information is recorded in a way that then the managed care plan systems can pick up and then give us credit for, because we have to meet, you know, HEDIS measures for the managed care plans as well. And then if there's any incentives, which in our case there have been from the managed care plans, that's measured on how well did we meet certain criteria with their clients, or their members. So that has been a challenge, because we know that we have performed, you know, gosh, many services under one visit. But unless that gets recorded properly and on the different systems, not just one, not just our electronic health record, then that managed care plan or those managed care plans might not be able to recognize that we did that work, and then they do not give us credit for it, which means that we will lose revenue. So before we get into some of our lessons, more lessons learned on that, I'm going to turn it over to Tom to just describe, you know, how the ICD-9 and 10 codes, you know, what the differences are that we saw, and what we've done to basically, you know, get on board and prepare for this before it was actually implemented, and how that really makes a difference for us in terms of the physician time and obviously the experience that the patients are going to have when the physician is all the time busy on his laptop or his computer instead of, you know, really focusing all the time on the patient. It's really changed, I think, a lot of the patient experience, which brings in the scribes and the coders. So I'm going to turn it over to Tom here. I just wanted to say that, you know, our pediatrician the other day was saying, gosh, you know, before it was like one code as an FQHC. We had, what, 1 or 5 codes, but mostly it was 1 or 2 codes we were always using as a FQHC and, you know, for a primary care visit. And now that one visit as a ped visit is now really broken down into 7, 8 codes. And unless we list them all, nobody says that, yeah, we did this or this during the well child visit. So that's a huge difference. So let me turn this over to Tom.
Thank you. So with the transition from paper charts to electronic medical records, you know, especially with ICD-9s and transitioning to ICD-10s, just the practice of medicine over the past 25 years has changed so dramatically. There have been so many probably new conditions that have been discovered. ICD-9 and ICD-10 went from 13,000 codes in ICD-9 to about 68,000 codes. And the new codes in ICD-10, it gives us a lot more specifics in terms of reporting, which allows more information to be conveyed in a single code. So the terminology has been a lot more modernized. So instead of just a code for, say, leg pain, it gives more specifics like right versus left destinations, and it reflects more the importance of which side of the body or the leg is affected. So we have more specifics like left arm, left kidney, left eye. So although there has been a lot of changes drastically, the ICD-10s are a lot more reflective in terms of terminology regarding the codes that we use today. And they're so specific, they're almost absurd. We make jokes all the time. You'll have a code specific to like an alligator bite on your left arm, roller skating accident code, being bitten by a cow. So it's pretty funny and almost absurd how specific it is, but it is really important. And it's something that we've learned in adapting to a new HR environment. So like I said, we've transitioned from paper charts to electronic records. One complaint from providers is how long it takes for them to actually focus on a patient. So they're spending, we're hearing that they're spending a lot more time in front of the computer instead of face-to-face with a patient, which is how they really should be spending their time. One complaint from providers is that they're spending so much time to log into their applications. We're spending so much time going from computer to computer, from exam room to exam room. So one of the things we implemented is called a tap-in, tap-out program, which actually saves providers valuable time from having to reboot their computers, logging into our next-gen EHR system, logging into the internet, logging into their computer, Microsoft computers in general. They're able to go from room to room, and it allows them instant access with just a simple tap of a key. So they can go from exam room 1, be in a patient's chart, walk over to exam room number 9, tap into their new computer, and that exact same page will appear on their computer. So the terminology from ICD-9s and ICD-10s and how we've adapted using computer technology has expanded, and it's one of the really big learning lessons that we've experienced and that we're able to use to strengthen our practice.
Thank you, Tom. And I've also heard many times from the providers that they hate clicking. They have to click how many times. And so our IT folks have been really creative in designing these drop-down screens so that, you know, it eliminates individual clicking all through that chart by hitting different groups of selected items there, and depending on the diagnosis and so forth, and then prompts in the system that then remind the physician, the provider, to you know, to then look at other areas or other parts of care, you know, other referral options, because we have many of those specialty services inside our organization. Not that we're forcing all of our patients to go that way, but Sometimes the providers don't know that we offer imaging, for example, or optometry and so forth, so they'll have a screen drop down that reminds them of that. Managed care, we talked about the managed care. IPAs are, Ale, do you want to define what the IPAs are for those that haven't met this animal yet?
Sure. IPA is Independent Practice Association, and basically it's a group formed by anybody that wants to form this group, where they start contracting individually for members for the health plans. For example, at La Maestra, we negotiate directly with the managed care plans in San Diego to obtain our rate for the per member per month capitation. But if we would choose, we could form an independent practice association with other health centers so that we would negotiate for all of them at the same time for all the members, and then the members would get some kind of reimbursement after all of the expenses are paid. Independent practice associations has been challenging throughout the years because most of them not only contract for primary care, but for specialty care. And for specialty care, then they are at risk because the IPA has to pay the bills of the primary care doctors, but also of the specialists. And if a member has a huge bill because they had a surgery or something like that, that's where the IPA can be in trouble and become even bankrupt. We've had this in San Diego for the last 10 years, and then most of them have disappeared. And now with the new changes in healthcare, some of them are coming up again. And I think that is one of the areas where everyone joining one has to be very careful to see how they're going to fare out in the end, because the expenses incurred by the member patients of the IPA that the IPA contracts responsibility for. So it is something to look at, because for federally qualified health centers, as you know, we're mostly primary care, and we should be really just taking care of the primary care needs of the patients under under capitation.
Thank you, Ale. And it also depends on, how ill or how sick the population is. It's basically ideal to manage care of healthy patients because the costs are going to be a lot less all the way around. And that's what it could kill an IPA, is if the in general, because populations maybe have not had access to a lot of preventative care or not much care available, like people from other countries, refugees, immigrants, and so forth. I mean, that population is going to cost much more in terms of medical services than a healthy population that's had access to healthcare all of their lives. And then, of course, with the IPAs, it depends, like, what are they going to take risk or not? And that's a whole other kind of challenge. If you take risk, then you stand to lose quite a bit if you have some really seriously ill patients, or and if you don't manage the care through the networks that you've established as a group. And here in San Diego, it seems like there's certain geographic areas that it makes more sense to have these IPAs because there are not enough providers in networks in those areas. So by being part of an IPA, it makes sense for those FQHCs and those areas to really belong to these networks, because then their patients and clients have more access to specialists. Okay, so let's see, how did we end with this? Okay, all of these, I think, numerous topics about quality, from the electronic health record to the managing chronic disease, to managing the lives, the care from a network perspective, the IPA perspective, to negotiating with the different managed care plans, not just the capitated rate, but all of the other add-ons that, you know, one would never think of if one had never engaged in managed care contracting, like if we turn in the paper claims, the data claims electronically versus, you know, paper, we get, you know, 30 cents per member per month. That's just an example. Or within a certain amount of days, if we can turn into the managed care plans within 90 days, what it is, you know, the data claims that, you know, what services we provided to their clients, then that's extra per member per month. Also, the whole incentive, usually managed care plans have an incentive plan that is dependent on how much monies the state then gives to the managed care plans, because they have supposedly saved the state money by managing these lives. Then at the end of the year or whenever that time is up, they give the managed care plans a block of money, and the managed care plans turn around and divide it among the private physician offices and the FQHCs and the hospitals and so forth, however they want to. And it's usually based on a reward system. The managed care plans want to look good with the state. They want to meet their HEDIS measures, so they will reward us and other providers that contract with them to manage their members' lives, depending on how well we do that. And if we can hit certain outcome measures, like, you know, if we, for example, one of the managed care plans was saying if we can close and make sure that all of our charts, you know, under a certain period are all closed, and that we've listed all of the codes we need to in there according to the ICD-10 codes, and populate that and get them over that information within a certain amount of time, and that they can find this and validate, verify this information on their system because we've transmitted it electronically, then we would get X, you know, for the incentive. I mean, it can be numerous methodologies that, you know, that we could negotiate with them, like, you know, urgent care hours. Could they help us on that so that we can increase the access to more of their clients or their members after hours, so they don't end up in the emergency room and cost those managed care plans a lot more. Those are all negotiating techniques, and that would bring in more reimbursement, diversified reimbursement to the FQHCs. Then we have the whole issue of volume to value. That's an initiative that CMS has, you know, rolled out, and different states are incorporating it sooner or later. And here in California, there's a pilot that's going on right now, not in San Diego, because of our numerous managed care plans. They're going to wait and roll this out in San Diego County probably, I don't know, 2-3 years from now, if then. But basically, it is shifting the reimbursement model from a volume-based model to value. If the FQHC can demonstrate that the services and the case management and the quality, customer service, everything has added value for those patients, then it will be reimbursed accordingly. It's something that, you know, still is yet to be determined, really, the details and so forth, which is why it is a pilot. But it is a totally different way of approaching reimbursement for FQHCs. And if we're not prepared, and if we haven't done our homework on this and participated in, you know, all these webinars throughout our state, and keeping track of how it's going in the evaluation process, we could stand to lose a lot in revenue. So that's something that we're looking out for quite a bit. Another impact to our revenue has been because of the exchange program, and that is, we call it Covered California here in California. And La Maestra has in Southern California the largest outreach team that is actually certified to for eligibility and enrollment for this state-sponsored, actually federally sponsored health insurance plan under the ACA model. Well, we in San Diego are still left with a lot of uninsured patients, patients that don't want to enroll, patients that did enroll, but then they found out, gee, they have a huge copay or deductible, or the medication is so expensive with their plan that they, that they just they opt out basically, or they don't like the idea of having to pay taxes on the subsidy for the health insurance at the end of the year. So it's been very interesting. Of course, those patients that have chronic diseases, this has been a real blessing for them to be able to finally be admitted to some kind of coverage without worrying about, existing prior conditions. So this is really a blessing for them, and for that, we're grateful. But we still have patients that want to come and self-pay here, and they have already enrolled in an insurance coverage somewhere else. Used to be when they would show up and they say, well, we don't have anything, and we'd run their information, and we wouldn't be able to find if they did have insurance somewhere else, and we would just take them as self-pay according to our sliding fee scale. Well, now now basically there's another regulation that has been issued that that basically says we have to curtail that. Ali, do you want to talk about the poverty?
Yes. What happens with the self-pay patients that have some insurance, according to and of course, to everybody that is under the 200% of poverty that doesn't have insurance may qualify for the sliding scale that we all have an obligation to give because of the grant that we have. So the newest spin from HRSA has been that if a patient comes in and has insurance, but some services are not covered by the insurance, then those services that we offer them can be provided to the patient under our sliding scale. Of course, they have to register, and they have to prove that they're under 200% of poverty. So that's kind of like another area where we have to be careful, because it's not just that the patient is uninsured. Now it's that if they have insurance that doesn't cover services, then those things we can roll them out or give them as services under the sliding scale. So we all have to have registrars that are, when the patient comes in, they have to prove their income and all of that. And of course, as you know, we cannot give services for free because we are an FQHC, so we have to be always up to date on the latest regulations issued by HRSA and the PINS and PALs.
Yes, thank you. So I guess that would cover many patients that are underinsured, correct? Or their insurance plan does not, like especially imaging. I mean, CT scans and MRIs, I mean, they still have to be out of pocket, thousands of dollars. So it really doesn't matter at that point if they're covered or not. Medications is also another big one. If the plans that they're going with do not cover their medications, or their copay is so huge that they can't afford it, then it basically doesn't really help the patient that much. And how does that play into your 340B formularies and access is another challenge to look at, and who is accessing your 340B. So some of the unintended consequences that we've seen with the implementation of the exchange program has been that our patients seem to be more limited in access with the specialists because they are joining certain networks, and those networks then might not allow FQHCs to participate with their patients because they consider that the patients of FQHCs are sicker and they're going to take more time, and then the reimbursements to those specialists and hospital systems are not as much as if the patient had commercial insurance. So that's something that we've seen. And then the more development of these closed systems. The hospital systems that we have here in San Diego, majority of them have been just for inpatient care. Maybe some they contract with some specialty private providers groups, but they don't do primary care. Well, now with the ACA implementation, we've seen them try to grow primary care arms and keep it all within their system. That means that the original intent, which was that the safety net providers would be part of this model under ACA, was so that the FQHCs would be providing the primary care, they would be the medical home, they would still be the medical home, and then the specialists would be part of the network and the hospitals and ancillary services. But with the hospitals growing their own primary care arm, that kind of cuts out the safety net. So we've had to look at what else we could partner with these hospitals and then try to keep our place in with the whole contracting arena so that we don't get cut out of being able to participate in these networks and these and having our patients then not be able to access the specialty that that they really need for their care. That's another reason why we've been working on the telemedicine and e-health for 12 years now, because it's much easier to contract with specialists that are across town. They are usually not living in our areas where our clinics are, and they don't have their practices there. So if we block out 15 minutes of their time, then we're able to keep the patients here, have the language capacity, have the patient's charts, have the primary care provider here, medical liaison, all of that. And then the specialists and their staff stay in their office across town, and they're able to effectively treat the patient through telemedicine. We have scopes, lenses, cameras, and it's really cool, and it's very, very effective. The patient feels like they're part of this experience and part of their own. They then become a willing participant of their own health management because they have the primary care there, the specialist is coming via the monitor here, they're seeing and talking to them, health education is delivered, and everything is explained to that patient. It's really cool. So I would encourage you, if you haven't looked into it, try to get in on some of these webinars about telemedicine and e-health and how to incorporate that into primary care. Okay, the next biggie is the shift from the PPS system, our Prospective Payment System, to an alternative payment model. The goal was, the way it was rolled out, was to eliminate this fragmented care and tie performance outcomes to reimbursement. There's pilots going on in California like we talked about. Ale, do you want to say anything more about some alternative payment model?
Well, I think that what is happening in California is that they have started the movement to get away from the PPS rates. For the last 2 years, the state has tried to reduce them, but now it seems now it's going to be, they're going to be more aggressive with the alternative payment model. This is something that we need to be watching every day, because the PPS system really, the money that we get from there really assists us in providing all of the ancillary services or enabling care that the patients need. And if that goes away, I think that the safety net, the FQHCs, will be affected. We don't think that that's going to go away totally, but we have to be, we would caution you that we have to be very attentive as to what will the alternative payment models look like. And in California, for example, our CPCA, California Primary Care Association, is lobbying and working with the state people very closely so that it doesn't, we don't get affected very much. So it is something to watch in the, at least in this year, and see what is going to come out of this.
Great. Thank you, Ale. Of course, anytime anybody says, oh my gosh, you know, your PPS, the reimbursement, the model is going to go away, and everybody's like, okay, well, I mean, we have to make sure that we're going to be able to sustain our clinics and, you know, our operations, and still be able to, you know, come up with the funds to pay for all of these quality measures, which has been increasingly more expensive with all of the connectivity costs between, you know, the electronic health records, and then having it communicate properly with your lab and with the pharmacy and with every other software program that we are required to have to be able to track the information that, you know, that basically the managed care plans and the state and so forth want us to keep. I mean, it's very costly, not to mention the amount of time, like we've said about, you know, the time that it takes the providers to get through all of the required charting electronically and on how many different systems, and still deliver that, you know, that focused patient care that, you know, is going to lead ultimately to the feedback from the patients on the customer service, which again is part of that value that we will be reimbursed on. So it's very complicated, but all of these pieces have to be tracked and prepared for as best as possible. And that leads us to the managed care IPA. We've talked about the revenue streams, the incentives. These incentives for us have been huge. I mean, the thing is, last year we've gotten from one health plan about, let's see, about $5 million. So that's why we keep mentioning the importance of these incentives, because a lot of this incentive money can be used then to backfill what the clinic's already spent up front on these quality measure software systems and so forth. The state reconciliations is like huge in conjunction with how we record on our cost reports those incentives. And if the incentive plans, I mean, if the managed care plans send us a check that says, you know, if it doesn't say incentive, then the state is going to count that as capitation, which we don't want, because then we're dinged for that. So we have to make sure with the managed care plans, before they pay out incentives, bonuses, and so forth, that it actually says that. Otherwise, the FQHCs will get punished by the state, and that will be, you know, included in their cost report. So that's something that I wish somebody would have told us before this got rolled out, and we would have known. Then the contracts, again, can't stress enough to keep, you know, looking for other contracts, negotiate the contracts with all those add-ons in there. Also, we've been successful with the managed care plans to say, listen, we are going to provide your members with managed care 101 orientation, health education in these areas, like when to access the ER, or what do you do after hours, because the managed care plans, even though they have patient reps, don't necessarily speak the language, and they can't get around to all their members. So it really is worth their while to pay us a certain amount per member per month, if we then here at the primary care level deliver that information and reinforce these messages with their members, save them money. I would suggest that any webinars that you can attend through NAC or through your statewide primary care association on, revenue cycle management, why to incorporate coders. We thought before, gosh, well, why would we need a coder? We have what, 1 code, 2 codes we're billing, all these years. Well, because like we said, now with the ICD-10 codes, there's how many more codes that you need to record with that 1 visit. Otherwise, you're going to get penalized. So that's the importance of coders. And then coders that are familiar with, working with FQHCs rather than private physician offices. It's a whole different arena. Then the use of scribes. Why do we think that it's important to hire scribes, to develop our own scribes, to to support that provider that might not be very comfortable with the computer, with the electronic health records, no matter how much training you provide, but they're a fantastic provider. Maybe they've been a doctor in underserved areas, but totally devoted to patient care, and it's got a great customer service attitude and so forth, but they hate doing all of these charting requirements. So we definitely have scribes to help them out, and also to help out those top performers, because the top performers, are providers that are very comfortable with using all of these computer systems, but they are they also need scribes so that they can then keep whizzing through the visits and documenting them and moving on to the next patient and basically increasing the access to care. So scribes are very important. And the whole PCMH model, patient-centered medical home model that we've incorporated, for years, and meaningful use, of course, with the EHR, all of those are very pertinent, and I can't tell you how much, if somebody were to have told us, 7 years ago, of course they didn't know, but, like, hey, this is what you're going to end up being measured, graded on, and reimbursed on, are these different programs and how well you implement them and what that's going to then lead to down the line, and how much all of this is going to cost you, and how are you going to then go out and try to recoup some of these costs. It wasn't just the EHR. It's been all of the other software programs, and the loss of time training people and supporting the providers, and the wait time for the patients. So anyway, with that, we're going to stop and basically entertain questions, or like I said, please feel free to send us your questions. A lot of this we've already covered, the bonuses, the coders, and so forth. Data analytics is big. We're piloting a program with that right now, and the effectiveness of the medications for the chronic disease diabetics. Thank you.
Thank you very much, Zara, for this wonderful presentation. We're going to start our Q&A section. If you have a question, please feel free to submit your question to through the question box on your control panel, or if you dial in through your phone and you would like to verbally ask Zara a question, use the raise hand icon on your control panel and your line will be unmuted. While we wait, Zara, for some questions or a question, I have a quick question for you. Do you work with private or non-profit organizations? For instance, if you have an uninsured patient and you mentioned the image services, this patient has a disease breast cancer, for instance? Do you have any any of these private organizations who can sponsor one of these patients or help these patients?
That depends. I mean, recently we've had the Susan B. Komen Foundation that pays for diagnostic, advanced mammography and, biopsies. We have the state-funded Every Woman Counts program. Of course, that's for the treatment, advanced diagnostics and treatment. That wasn't always around, but, it is now, and it depends on the age and you got to qualify for the program. But basically, we're very grateful that that program now does exist, that and Komen. So yeah, that's there. For other, it's unfortunate that we don't have those kinds of resources to send our patients for, when they're uninsured and they need these other, like surgeries and so forth. There's some programs hit and miss. There's the Fresh Start Surgical that's up in Oceanside, about an hour and a half away, that'll accept people that have been born with disfigurements, and they'll do these free surgeries every month or two if they qualify. So that's one area. But really, it's negotiating. Our success with that has been negotiating with these same surgeons, specialists that we send patients to that are paying, and negotiate with them, leverage, let's say, and say, look, we send you X number of paying patients. Now we want you to provide X number of pro bono visits. And that's really how we end up negotiating their care.
All right. Thank you, Zara. Thank you for your response. I do not see any questions, Zara. Brendan, do you see any questions on your end?
No.
All right. Thank you. So let me ask you this other question, Zara. The ICD-9 into ICD-10 transition, I understand that it has make these that there have been some changes in reimbursement. Now, have you seen any improvement, or this is just getting worse?
It just kind of started with the ICD-10 and so forth. But, it's like if somebody were to ask us about the quality of the care, I would say the quality of the care was always there. It's just that it's how it's being measured and how those measures are being recorded and transmitted to the different powers that be. That's what is being, a focus right now. It's not like I could say, oh yeah, and because of all of these programs that have been imposed on us as FQHCs, that now we provide quality care. No, we've always been providing quality of care.
Yeah, okay. Thank you, Zara. And well, we don't have any questions. So if you have any questions for Zara, please feel free to email her directly. Her email address is on your screen, or you can also send me your questions, and I will be more than happy to forward your questions to Zara.
Thank you.
Visit our website, the National Center for Health in Public Housing, www.nchph.org, and you can find past webinars, publications, monographs, information about the HRSA's updates, annual symposiums, fact sheets, training manuals. You can also join our mailing list and receive HRSA updates, Medicare updates, information on funding opportunities, resources and services. You can also follow us on social media. You can follow us on Twitter, on Facebook. And if you have any questions, you can contact any of our talented staff, and we'll be more than happy to help you with any training or technical assistance request. One more time, I would like to thank Zara and her staff members for this wonderful presentation. Have a great afternoon.